We are doing evaluation, and that evaluation includes monitoring of the data. We look at patients educated and connected. We've done a regression analysis on the types of patients likely to keep their appointments, as well as a regression analysis on the impact of the program on the emergency department. And as part of that, we're also doing a financial analysis to try and understand the impact. So far, our initial data suggests that we're seeing, as a consequence of this program, about a 4% reduction in recidivism. That is the number of patients who return for ongoing care in that low acuity profile. We've also seen that the impact on the program, the financial impact of the program, is substantial if we were just to look at those programs who, rather those patients who have Medicaid or those patients who are in a no-pay status currently, so self-pay. If we add in those patients who have private insurance, then the financial impact at this point is a wash because of the dollars represented by those private pay patients. This program is open to both public, private, and self-pay patients. We plan to track the medical home stickiness, meaning those patients who not only show up for an appointment at a medical home but then stay there, because clearly that's one of the major goals of the project is to get patients into their primary care medical home permanently. And we're looking at ways to try and improve our success rates at getting patients to keep their appointments. Next slide. So, of course, we've learned things through this process. And we've tried a lot of different things, as you can see listed there, to try and improve the rate at keeping appointments. And we really have not seen a substantial change over the course of the program. So we're now trying to understand who keeps appointments and who doesn't, so maybe we can do a better job of directing our efforts. And we're also starting a texting program to see if perhaps sending text messages to people will further improve the show rates. I already mentioned that funding is challenging, and it's part of the reason why we want to look at the financial impact. So that way, we hope that going forward, we will be able to use that to continue to attract appropriate funding for the program. We know that communication of information out to the collaborative sites is critical to continuity of care, and we've built a portal which allows us to actually direct information to the sites that the patients have agreed to go, so that way they can look at the information that's been generated in the emergency room directly, rather than having to depend on a faxing or mailing system, which we found did not accomplish the task, which was often that information was lost in process. And then finally, getting people into subspecialty care is certainly a challenge. We know from data that's specific to the South Side as well as national data that trying to get patients into care who are public pay or are self-pay is a true challenge. And we are trying to change the landscape in terms of both addressing need and as well as trying to improve the finances of institutions that are interested in providing service to this population. So through that, we've developed what we call Project ECHO, which actually is a up-training program, taking the example from New Mexico and applying it into an urban center. We're the first university, and in fact, we're the first program to do that. And then we're working very closely with our community partners, including the Cook County Health and Hospital Systems, and we've developed with them a system called Iris for Kids, which helps to move patients in a more seamless way into an appointment at the county health facility for follow-on care, depending on timing of that care and the availability both at our own institution as well as through a subspecialty partnership program that we've developed with one of our federally qualified health centers, which is the Grand Boulevard Health Center of the Access Community Health Network. And then finally, we've developed a diabetic retinopathy program, which allows an FQHC to be able to send a picture of the retina of patients to our retina specialist for review, and then based on that review, a determination is made about whether or not it's necessary to make a appointment to see the subspecialist. In this way, we can more effectively use the time of our subspecialty providers. Next slide. So we plan to sustain and expand this program. We are continuing to receive internal support, but of course we believe that sustainability is going to be tied to external funding. And we continue to look for opportunities to expand our program, including encouraging other Southside emergency departments to take up the Medical Home Connect program, as well as to expand it to our inpatient floors and outpatient specialty clinics, because often we find that there are patients who need a medical home from those locations. We're finding that those sites are within our own institution are using our patient advocates even now to help with identifying a primary care medical home. Next slide. So here is contact information. We're very happy to talk further. We recognize that this format allows time for questions, but we assume that there will also be other questions or information desired, and we're very happy to continue this conversation with you in that fashion should there not be enough time for questions.